Welcome back to the show. I am Dr. Alex Earl, and today I have Dr. Ryan Gavin joining me. And on today's episode, we are going to be going over a very pertinent a bit of information in regards to, excuse me, the 10 things that we should know about low back pain, or specifically the 10 things that we think you should do. 5 do's and 5 don'ts of low back pain. And this is a PDF that was put together by 2 really well-known and well-respected professionals, Dr. Derek Griffin and Professor Peter O'Sullivan. And so we just wanted to share this information on managing long-lasting low back problems. Like I said, Dr. Ryan Gavin is joining us. Ryan, why don't you start us off with the do's, and I'll finish us up with the don'ts.
Sure. So number one, starting with the do's, number one, know that your pain is real. I think that is, it's difficult for patients sometimes when we are trying to, especially when it comes to something like nonspecific low back pain. I think that can be misunderstood as it like all being in your head. But for patients, that's one of the most important things, is to know that it is real. And that we're there to help with that.
I think that's a good point, because we want them to know that they're not faking it, that this is something that it's very real to them. There's no doubt about it. And so if you come across condescendingly, you're in essence going to lose a patient. And if you lose a patient, then you can't impact them and you can't influence them. So you don't want to lose the patient and be a negative impact on their journey, because you don't really know what people are going through. And also you don't know what other factors might be involved. And so it's also a really important component. Their pain is very real, and it's very real to them, which makes it really an important factor for us.
Absolutely. Number 2, stay active. I think this is a tough one to dispel, because I think the bed rest, or like stopping all activity that you might feel pain with, it's advice that's been given for just so long that I think most people are surprised when they hear one of the best things you could do is actually stay active and move as much as you can, things like that.
I've even gotten this from like a close friend of mine who coaches soccer, and he just assumes just, stay off of it. It could be a bad bone bruise. It could be something more serious. And his default was always, yeah, so just stay off it, just rest for a little bit. And I'm like, well, yeah, in some cases that wouldn't be the end of the world, but that's just his go-to for everything. And like you said, the literature supports a more active component to chronic low back troubles. And so I love that this is in there, because we certainly should stay active. It's good for not just our physical recovery from a discomfort or a troublesome back. Also, there's psychological components. There's getting up and going for a walk mentally could be very, very beneficial. So yeah, absolutely staying active and not overdoing any bed rest. That can't go without saying. That's certainly an important factor.
And I think that's one of the part of the art of treating, right? For what we do is figuring out ways to still keep people doing what they want to do, staying active in some way. Maybe you need to cut out 1 or 2 types of activity, but there's still plenty you can do, and ways to modify stuff even. And I think that leads into number 3 pretty well, and that is sit and move in a variety of ways. We know there's not one best posture, right? So keeping up the variety of positions that you're stuck in for long periods of time, and the movements in general that you're doing, I think is that should be a go-to advice for any patient.
I think it's also important that they're already in a doom loop, right? Like, this back is hurting, this low back is hurting them, so they don't want to move it. So then when they go to move it, it hurts. And so then therefore the loop just continues in on itself. So I think like before we hit record and hopped on this episode, you were talking about how, a patient was told not to deadlift anymore. And so it's okay, you can't deadlift in this phase of life, but what can you do? I think there's certainly value and merit in finding these different variety of ways that people can move. Movement, shouldn't be rigid, and there should be some flow to it. There should be some new movements that you maybe have never done, but I don't think that there's one box and we all have to fit in it. And certainly posture, that's probably an episode on its own at a later date. But I
Mhm.
think that you're right that um, I think it's common and it's normal to want to protect the spine. Not a lot of people understand the spine, but it was built and it was created to move. And so if we find that it hurts moving in one way, that doesn't mean we can't move it in other ways.
Yeah, that same point leads into number four, that is focusing on meaningful life activities. Um, Whether that can be something that it's a meaningful life activity that your pain is actually keeping you from, or a meaningful life activity that can be something that kind of is involved in your rehab or kind of progress. I think that's a huge point and should be involved in the plan.
Yeah, I think that's one reason why a lot of smart people, a lot smarter than me, ask patients, what if you didn't have this pain, what would you do? And then you're focusing in essence on the thing that they're missing out or the thing that they value that they can't do because of this low back pain. And so that's a loaded question, and it opens up the possibility. And then in our office, as you know, Ryan, that our patients, when they answer, however they answer that question, that becomes a key data point in their treatment plan, right? If a
Mhm.
patient can't bend over and pick up their child because their back has been bothering them for 2 or 3 years, okay, then being able to pick up your child and embracing your child is a meaningful activity. Like, we will get you there. We will do everything in our power to get you there. So it's absolutely important to prioritize some movements and also these meaningful activities over the pain that you're currently experiencing.
Mhm. Number five is maintain your social relationships. Um, I think a lot of times pain can kind of make people feel isolated, especially if they're not if it's keeping them from an activity or doing something that they love. And that's one of those things that we kind of know is super important when it comes to recovery. Is one of those real baseline factors that kind of get overlooked sometimes.
Yeah, you're right. I think it's really easy to fall into that isolation um, state. And just like when I was injured in college, or when I've seen athletes get injured, one of the best ways to stay mentally engaged is to still go to practice, to still pick up the cones, to help with water, to just contribute in an area that you otherwise wouldn't be because you'd be out there playing. And I think it's also, for CrossFitters that maybe have back pain or spine pain, still go to the gym. Don't
Mm.
avoid that social camaraderie. That the wonderful thing about CrossFit is it's a really tight knit community. And this also goes for other social gatherings, like family gatherings. If you got some low back troubles, I think you should still make every effort to get up, get out of the house, and even if it's for a short period of time, you're still going to be blessed by being around your family, which maybe that's a good thing for some, maybe it's not. But I think that you're taking an active approach to an otherwise really difficult situation, and I think that's commendable.
Definitely. On to the don'ts.
You betcha. All right. So, in regards to the don'ts, it's really important that you don't blame yourself or fight your pain. And this is a mantra, maybe from our parents' age or just different generations, to just think that pain is a sign of weakness. And the old weightlifting T-shirts of pain is just weakness leaving the body. And while that might be just a method of getting through some type of workout, someone that's dealing with chronic or persistent like low back pain, that's actually not like a very appropriate mantra or an appropriate mindset to have, because pain, we know, can affect all shapes, all sizes. It can affect all ages, and it is completely individualized. No one person will go through the same low back experience. So it's really important to take the small steps, right? Like, the way to eat an elephant is one bite at a time, and to just know that you don't have to fight this. You don't have to blame yourself, and you don't have to fight it on your own.
If it's weightlifting, say something that you should be doing is good for your health, is good for your mental well-being, that you injure yourself doing, blaming yourself is a good way to put a block up and not return to that activity, which long term is usually not the way to go, not something we want, right?
Yeah, it's really funny because I actually had a spine injury treating a patient. And every time I want to get back into that same position, I think like, you idiot, don't do that. Don't do that again. Don't do it. And so I've just avoided that position for a long period of time. And then, rereading through all this, it's very relevant that I for sure was blaming myself. So even patients that are going through spine troubles, like you are not alone. We also, we're not perfect. Contrary to what my wife says, I don't know what your wife says about you, Ryan, but we are not perfect, and I think it's important to not lose sight of that. So, all right, nice. Number 2 on the don't category: don't assume long-lasting pain always means damage. This one, we could probably do a 3-part series on tissue damage. Pain equals tissue damage. I know I've got a lot to say on it. Ryan, what are your thoughts about always wanting to blame the tissue damage?
This is another old wives' tale about pain that is super difficult to dispel. There are very few patients, I think, when we have this conversation that are actually aware that like the amount of pain you're in, or the fact that you are feeling pain with a certain movement or activity doesn't mean that you are damaging the area further or making your issue worse. And I think that goes back to kind of some of the news, why we want to keep people staying active, why we want to keep trying different movements and positions, is so that we can kind of show them like, hey, you can do these things, and it doesn't mean that you're, just because you are experiencing some pain with it, doesn't mean that you are making anything worse.
Yeah, I like the analogy of the like the alarm. Pain is analogous to an alarm because, and I said this to a patient not that long ago, that if a fire goes off in the house, or at least if the fire alarm, I should be very clear in what I'm saying here. If the fire alarm goes off in the house, do you know where the fire is? And do you know how severe it is? No. All you know is the fire alarm went off. Get to safety. Get out of that. Get your loved ones and get out. And then I ask patients all the time, what if I told you pain was the same phenomenon, where just because an area hurts, we don't know the intensity, and sometimes we don't even know the proper location. And so it's really important to understand that soreness is very different than pain. Pressure is very different than pain, and even compression. Those 4 categories are very different, but oftentimes patients present with a soreness complaint, but they use the word pain. And I'm a stickler for words. I think it's really important that we use our words carefully, and because it's important that we don't increase the fear or the anxiety in associated with pain, in regards to assuming that it is only coming from the tissues. So nice, good stuff, really good stuff. So number 3, we're moving on to number 3 on the don'ts category. Don't rush or panic if you have a flare up. I can share a personal story here. When I injured my patient, when I injured my back with treatment of a patient, I was probably the worst patient when I knew the injury took place, and I rushed, I panicked. Goodness, I was in an MRI unit maybe 6 hours after not 6 hours, maybe 10 hours after I hurt myself. No, I knew exactly what I thought I would see on the MRI, and I thought I would see a 10 to 12 millimeter disc herniation, and because it was so bad. It was terrible. I was in a lot of discomfort, and it was I had a 3 millimeter disc herniation. Who's to say it wasn't already there? I don't know, but I rushed to getting an image, and now I have the image like permanently ingrained in my mind. And it was because I rushed to it. So I know that's an all too popular or all too common thing to just rush and get this figured out as soon as possible. But yeah, people's journeys with pain is often full of ups and downs. And so let's not rush to judge our current situation or panic if you have a flare up.
And I think this one is goes hand in hand with that point before of not thinking that injury or pain getting worse means that more damage is occurring. I feel like that happens all the time where you're a few visits into a treatment plan, the patient comes back and they're like, oh, it was getting better, but it kind of came back, or I did this and I made it worse. So that probably means like, what next? Do we need some imaging, or do I need to go get an injection? Where you got to have that conversation and be like, no, that's pretty typical with the recovery path. You're going to have good days, you're going to have some bad days. It's not a straight line, that progress you make. There's going to be some ups and downs in it.
Yeah, that's another component too, because with most, if not all, chronic and persistent low back situations and low back cases, it's multifactorial, right? So how someone sleeps, if someone gets into a car accident or at least a fit of road rage when they come over, like we know that you're going to have a more sensitive nervous system, or have a more sensitive um, like threshold. We'll have like a lower threshold to the same stimulus that previously didn't cause any low back trouble, right? So it is really important to just keep in mind some of these other factors involved, like your previous activity, as I mentioned, sleep, and even the ability to relax. So yeah, it's important to keep an open mindset on that. Moving on, number 4 on the don'ts category: don't believe everything you hear or read. I think that goes without saying that, not everything you read or see on the internet is true, and could be categorized as misinformation. And I think it's really important that when people are in pain, it's very understandable that they will try anything. And oftentimes you've heard this a bunch with patients, Ryan, that they've tried everything. And I always want to think, really, what's everything? What is everything? And it ultimately comes down to maybe 3 to 5 things that they've tried. Not everything, but it is important to know that there's a lot of nonsense out there in the world, and there's a lot of correlated things that are online. And like for example, soft tissue. There's like a bunch of nonsense online about soft tissue, and we teach soft tissue. So it's tough to listen to people just roll out with a little crossball and think all the pain in their foot's going to go away, or what I mean, just get a massage and this low back trouble is going to be fixed. It's like, well, it's slightly more complicated than that.
Mm-hmm. There's these myths that are just perpetuated, even by professionals, and even reading about big sports injuries that happen. I remember one of the most frustrating ones was it was a baseball player who like re-aggravated ankle injury, and they made it sound like he said something about how the scar tissue almost had a mind of its own. He's like, oh, the trainer said the scar tissue just jumped out of my ankle, and we gotta like give it time to sort of calm down. And this was published like everywhere.
Well, yeah, because
So
people are either trying to make a name for themselves. Like, hey, I can't speak for their intentions for putting stuff online. I mean, people make up anatomical things all the time. They make up biomechanical things that aren't in biomechanical textbooks, or any anatomy and physiology or biomechanics textbooks. They just made it up, and
mhm.
and so it's really important to sift through the nonsense. But if you're a patient, you don't know. You don't know anything.
Right.
So it's really important for us as professionals to understand where our patients are coming from, and then to like sift through that and then boil it down into bite-sized chunks. We are on to the 5th and final don't. So we will discuss here now the don't rely on scans to tell the whole story. I mean, I already mentioned it a minute ago about my experience with an MRI. I was expecting it to be way worse than it was. But it is really important that people often see changes to normal anatomy online and think that they are damaged. They think that they've got these bone spurs, they've got these Schmorl's nodes in their spine, and they just immediately think less of not just themselves, but what their body is capable of. And as I mentioned earlier, we are a very default positive office, and just default positive people. And so it's really important that these images could do harm, right? If you see there's another study that was looking at 40-year-old asymptomatic low backs, and they all had changes in the spine. Okay, if they don't have any pain, and we're looking and comparing the spine of asymptomatic people with symptomatic people, maybe there's not that big of a difference on what the scans look like. And that's the point here, is that the scans don't tell the whole story.
Mm-hmm. And we kind of had the opposite experience with our personal image, uh, our personal images that we had done in the last few months. Whereas your pain was really bad, and then your imaging came back and there wasn't a ton wrong. I had just kind of a nagging ankle issue that wouldn't go away, and got an MRI done. And I just remembered reading it and being like, wow, if I was a patient, I would think like I'm not going to be walking for much longer,
Yeah.
you know? So
It's also important to not internalize the way that the report of the image is written, right? A radiologist, writes what they see, but they have no, well, the good ones do, but most radiologists, they have no comprehension of the weight of their words. Like they're just looking at the tissue through the lens of the imaging device that is sent to them, right? And so it is important to understand that someone could read that. And this did happen in our office here. Someone came in with low back pain. They brought in their MRI. That was a referral from their primary. The MRI report said that they had these Schmorl's nodes, and this guy was distraught that his spine had these nodes. And you and I know that that's an anatomical variant, or it's just a process of dare I say it, aging. They just occur naturally as we age in the spine. And they're not really linked with any pain presentation that I've read in any of the literature. You can update me if I'm wrong, but I viewed it as something completely normal. But like I said, this gentleman, mid 50s, was distraught that he had these Schmorl's nodes, and it was written on the report, so therefore it was in his spine, and he internalized it, and I could not convince him that it didn't mean anything.
yeah, and that's the thing. Those images they're written out for us to kind of go and look at and correlate with the history and exam and the presentation. They can look a lot more intimidating to the average patient that just looks at it, right? They go and see segment by segment, 1, 2, 3 things going on, 3 findings at each level in the spine or something like that. Where we go and look at that, and it's kind of like, oh, those are just some normal age-related changes that we would expect to see in somebody your age. So,
and I get it from the practitioner standpoint. If there's more changes on an X-ray, that's more that possibly could mean there's more treatment, needed, which means I'm needed more. And so, I mean, I do understand it from a business perspective, and also from a like a diagnostic perspective. Like please note that we are not advocating for the avoidance of imaging. There's absolutely treatment guidelines and diagnostic imaging guidelines that we adhere to very rigorously. So we are not anti-imaging. We just don't want our patients to leave after getting an image. We don't want them to think that that is the whole story, which is exactly what bullet point number 5 is here on the 10 do's and don'ts. So I guess there's 5 do's and 5 don'ts on the 10 bits of information from, again, I mentioned Derek Griffin and Peter O'Sullivan. We will include this booklet, or this downloadable PDF, in the show notes. And again, we will see you on our next episode next week. Thanks, guys.